Now I'll be talking to you regarding question about pulmonary embolism. We are getting a 72-year man. He's a case of chronic kidney disease, stage 4. He's short of breath, coughing up blood, tachycardia, normal chest X-ray. Best initial to rule out pulmonary embolism. The answer is ventilation perfusion scan. And I'm sure many of you must have gone for this answer. This also. Quite possible. But in this case, the answer is ventilation perfusion scan. Why? It is true that this is always the first investigation choice in a case of pulmonary embolism. But if the patient has renal problem, like this patient, and in this patient we don't want to give us contrast media because kidneys are already underworking, they are not working properly. So in such cases, contrast should not be given. Hence, the best option is ventilation perfusion scan in this. So let's learn more about. Okay. So as I told you, CT pulmonary angiography is always the best first line investigation in the possibility of pulmonary embolism. But in the setting of renal impairment, VQ scan is the investigation of choice. So let's learn in more detail about how to investigate a case of pulmonary embolism. Well, the classical triad that we get in case of pulmonary embolism is chest pain, dyspnea and hemoptysis. Write down. Okay. Right. So the mnemonic is PHD. PHD is a mnemonic, classical triad, but it's a textbook. It is seen only in 10% cases. Okay. Only 10% cases we see. Of course, this is the sudden onset of dyspnea is a usually predisposing, is a very common presentation. Point to be noted, why it is so important. Remember, 70% cases of pulmonary embolism are asymptomatic. 70% is a big percentage. Patients have no symptom at all. So that's why 70% total remain asymptomatic. Out of 30, these 3 together occurring is only in 10%. That means in that rest 20% patient may have any 1 or more or 2. 3 may not be there. Understood? So, and moreover, these 3 symptoms are so common which can occur in so many other conditions. So that's why it really becomes difficult at time to think about pulmonary embolism. So, what the guidelines are? Okay, so there are certain guidelines. The guidelines are what they saw. Let us see the common symptom that we are talking about. How common are they? So they are thinking about the frequency of different symptoms. Okay. So tachypnea, and now point to be noted, tachypnea they are taking as more than 20 heart or respiratory rate. Point to be noted that in curve 65 it was 30. Here they are taking 20. Don't commit mistake on this point. Tachypnea is more than respiratory is more than 20. This is seen in around 96% of the cases. Of course, symptomatic cases. crackles in around 58%, tachycardia more than 100, 44%, and fever in 43%. So in previous slide also I told you dyspnea is the most common manifestation. But why I am spending so much of time? There is a catch here also. Or the catch is, so catch is that, soon I will be talking to you regarding Wells criteria. This many of you know also, which are to see the severity of a case of pulmonary embolism. Wells criteria, tachycardia is consideration, not tachypnea. Point to be noted. In Wells criteria, they are using tachycardia than the tachypnea. Right? So we come back. Here he is talking about tachypnea. Okay, and tachycardia. Tachycardia 44% is 96%, but still Wells criteria is using tachycardia as a feature. Understood? So we are getting a case, we are suspecting to be a case of pulmonary embolism. So what the NICE guidelines are? NICE guidelines say that take history, examine the patient and chest x-ray. Why? Chest x-ray to exclude other pathology. Again a very important point, once we are done chest x-ray, that means there is no other pathology, that means there is no other parenchymal pathology. The purpose of chest x-ray is to rule out other pathology. Okay, so these three things has to be done. So NICE guidelines, we are getting a patient where we can have non-specific symptom or symptom, only one symptom, and we know the same symptom, dyspnea or cough or hemoptysis, etc. They can occur in so many other conditions. You cannot jump to diagnosis of pulmonary embolism immediately. So now the NICE guidelines say, first we go for rule out criteria. Pulmonary embolism rule out criteria, what they call as PERC as per the NICE guidelines. They say first you rule out whether we are dealing with pulmonary embolism or not. So what are the things? Okay. So they have given the criteria in 2020 recently. Well, one more thing, we all know that embolus come from the deep vein. Deep vein, so it is a venous embolism which come to the, and most of the time is a calf muscle, deep, as you can say, thrombophlebitis in the legs. Legs thrombophlebitis where the embolus come to the lungs. So what he says, there are certain criteria, so-called PERC rule, that is, and all criteria must be absent, so-called rule out pulmonary embolism. There are certain criteria which I am going to discuss just now. He say all criteria should not be there. Okay. So let us see what are the criteria. Point to be noted, this is to exclude pulmonary embolism. We want that this is not the case of pulmonary embolism. Criteria are age above 50 years, heart rate more than 100, saturation less than 94, previous deep vein thrombosis or pulmonary embolism, recent surgery or trauma in the last 4 weeks, hemoptysis, unilateral leg swelling, and estrogen use. So age above 50 years, heart rate 100, saturation less than 94, previous history of DVT and pulmonary embolism, 4 weeks surgery or trauma, hemoptysis, unilateral leg swelling and estrogen use. If these are present, then it is a case of pulmonary embolism. What they say, these should not be there. These should not, if they are there, then we are going against. So all of the above are absent. Then the post-test probability is only 2%. So point to be noted that they have ruled out, okay, this not, okay, he's a man of 40 year, heart rate is 90, saturation is 96, there is no history of embolism, no surgery, no trauma, no hemoptysis, no leg swelling, he's a male patient, no use of HRT, nothing. Then it is perhaps not the case of pulmonary embolism. So friends, these, or they can be asked other way around, what are the factors which predispose to pulmonary embolism? These are the factors. Well, after that, if you are suspecting, if you are clinically suspecting that patient has pulmonary embolism, now you go for Wells score. Wells score is what and how it is based on, and these are the findings you have to remember. The clinical sign and symptom of deep vein thrombosis. Point to be noted. He is talking about deep vein thrombosis. How do you know? Leg swelling and pain and palpation of the deep veins. Deep vein, you are palpating in the leg and there are tenderness is there, leg swelling is of the one side. How do you know? You can compare between the two. You can compare between the two, and if you are getting swelling, that means you are dealing with deep vein thrombosis. You get 3 marks. Alternative diagnosis of pulmonary embolism is very less likely. Patient get 3 marks. Heart rate more than 100, 1.5 mark. Immobilization for 3 days or surgery in the last 4 weeks, 1.5 mark. Previous deep vein thrombosis 1.5, hemoptysis 1, malignancy 1 mark. Point to be noted that it has made it beautiful with the number wise also. So I repeat again, patient having some feature, clinical feature or not, of deep vein thrombosis, 3 marks. Alternative diagnosis is not possible, 3 marks. Tachycardia more than 100 is 1.5. Immobilization for 3 days or surgery in the last 4 weeks, 1.5. Previous history of deep vein thrombosis with pulmonary embolism 1.5. Hemoptysis 1 and malignancy is there, we get 1 mark. So numbering has been done. So if the score is 4 or more than 4, pulmonary embolism is likely, but the score is less than 4, okay, then PE is unlikely. So Wells score give you a counting also how much score is there. So now we got a patient whose score is more than 4. So that means it is likely. That's the idea of getting the Wells score done. Yes, score is 6. That we are most likely he is a case of pulmonary embolism. Now what to do? First line treatment is CTPA. Immediate CT scan, pulmonary angiography, which I told you in the previous slide also. This is a first line investigation. But Okay, and now suppose there is a delay, due to any reason CTPA is not possible. What to do? You start anticoagulation immediately. Don't wait. CTPA may take some time. Even it has been done, it may take some time to get report. But don't wait for treatment. Start anticoagulation immediately. Now, catch point. Previously, it was low molecular weight heparin. But now, as per the latest NICE guidelines of 2020, they say that now you should use direct oral anticoagulation, apixaban and rivaroxaban. Okay, so to summarize what he's saying, you have done the well score and score is more than 4. It is more likely that patient has pulmonary embolism. Then go for CTPA immediately. But due to any reason, the delay in CTPA, start rivaroxaban or apixaban. Only 2 keywords to be remembered in this particular slide. NICE guidelines, let us say low molecular weight heparin is not the first line. Now apixaban and rivaroxaban are the first line treatment. Well, CTPA has been done and the report is positive. Okay, so what to do? Or the report is negative. If it is negative, then do proximal leg vein ultrasound. If you are suspecting deep vein thrombus, do leg veins ultrasound. Right? Understood? Although DTPA is negative. Now, right, so a quick recap. We got score more than 4. What we did? DTPA. Now DTPA report and we started oral anticoagulation immediately and we have used rivaroxaban or apixaban. Report come positive, you continue with oral anticoagulation. Report come negative, then you do the leg ultrasound. Now third scenario, we are getting a patient where the score, well score is less than 4. That means pulmonary embolism is unlikely. Should we leave them as it is? No way. Go for, NICE guidelines say, go for D-dimer test. Very, very important point. What he says that we started for in a case where we think we are strongly suspecting of PE, we went for CTPA or we went for oral anticoagulation. Okay, right? And we started anticoagulant also. And in case where when the score is less than 4, we arrange for the D-dimer test. What is D-dimer test? I'm going to discuss in a minute only. Well, we did the CTPA and now there is no chance of PE. Then you can very well stop anticoagulation. Score is less than 4. Okay, score is less than 4 or DTPA test is negative and okay, this is not a case. So then you can stop anticoagulation. So this is a beautiful table. This will give you summary of how to approach. Since this is a summary, so I'll spend enough time. If you know this table, this tell you what the NICE guidelines say. So what he says, you score the well score. We have done it. 4, more than 4, 4 or less than 4. If it is more than 4, it is PE is likely. it's likely. Go for immediate CTPA scan, but if there is a delay in CTPA scan, then use anticoagulation, apixaban or rivaroxaban. If the CTPA is positive, you have diagnosed that it is really a case of pulmonary embolism. If it is, and of course, then you continue. You continue with oral anticoagulation. CTPA is negative, then you think about negative. Then you do leg ultrasound to look for the clot in the deep veins. Well, you are getting a case where the PE score is 4 or less than 4. In this case, you will not do CTPA. This you will not do. What you will do? You will go for D-dimer test. Okay. D-dimer test. What is D-dimer? It is nothing but fibrin degradation product. FDP, fibrin degradation product. Okay. Get result within 4 hours. The test is positive or negative, I'll talk little later on. But if due to any reason you are not able to get D-dimer test, start anticoagulation. Point to be noted here also, when we were planning to go for DTPA and we were not able to do, but we started oral anticoagulant. Okay. So here CTPA, we want to do CTPA, we are not able to get the test done. Start oral anticoagulant. Here we are planning to do D-dimer test, but not getting start oral anticoagulant. The message is very clear from NICE guideline. Start oral anticoagulant, don't wait for the report if you are thinking that you are dealing with a case of pulmonary embolism. Well, the later on report comes, D-dimer report is positive. If the D-dimer is positive, then now you plan for CTPA. Even the well score is 4 or less than 4, but D-dimer is positive, then you plan for the CTPA. And if the test is negative, then alternate diagnosis, and then you can stop anticoagulation. It's a beautiful summary, okay, beautiful summary. And if you want to take a click, I can very well remove all this. Yeah. So I hope you are quite well aware that how to approach a case of pulmonary embolism. Okay. Well, look into the CT scan. CT scan. You can see embolus, black color. ECG. In ECG, tachycardia is seen. Okay, you get S1, Q3, T3. You get S wave in L1. You are getting S wave in L1. L1. You are getting Q wave. And you are getting T inversion, Q wave in L3. T inversion in L3. T inversion in L3, Q wave in L3, and S wave. This is the classical finding. But now come the gold medal question. Tachycardia is the most common finding, and S1, Q3, T3 is the most characteristic finding. But in some cases, you may get even bradycardia also. Sometimes you can bradycardia, what we call as paradoxical bradycardia. Paradoxical bradycardia. Sometimes bradycardia, so-called paradoxical bradycardia, can occur in some patients, right? So, golden line to remember. In pulmonary embolism with renal impairment, VQ scan is the investigation of choice. But otherwise, CTPA is the first line investigation to rule out pulmonary embolism. So now things are clear to you, your basics are strong. 70-year-old man, 2-day history of short in the breath and chest pain on inspiration, normal chest X-ray and ECG may be normal, chest X-ray may be normal, C-reactive protein etc. normal, observation with the normal. Which investigation is the first to be performed if you are thinking in terms of pulmonary embolism? Answer is well score. Okay. This is CHA2DS. This is for stroke. This is for pneumonia. This is for upper GI bleed. Upper GI bleed is Rockall score. And PERC score is again for pulmonary embolism, but this is done to rule out. This is done to rule out pulmonary embolism. But if you want that patient has pulmonary embolism or not, then you go for a well score. The well score is done, and the score is 4 or more than 4. Then it's a case of PE, and you investigate accordingly. Question number 3. We are getting a 62-year-old man. He has a colon cancer. He suffered from deep vein thrombosis, and he is being given anticoagulation with maximum dose of dabigatran. Maximum dose of dabigatran has been given. Dabigatran is an oral anticoagulant. Okay. On one occasion, he suffered a DVT, and during treatment, deltaperin was given, and now he has another episode of DVT. What you should do? So, point to be noted that he has a deep vein thrombosis. He has been given adequate anticoagulation has been done, both oral and by deltaperin, but still he is having recurrent embolism. What to do? So the patient fully on anticoagulation, but still having embolism, then you should insert an inferior vena cava filter. Let's rule out other technique, other question. Add apixaban to his prescription. No way. Already he is taking full dose of dabigatran. No need to add on to any other drug. Initiate end of life drug. No, he's not dying. This end of treatment that we do in a very terminally ill patient, he is perfectly all right. Increased dose of dabigatran. He already says he has been given maximum dose. No use of adding the dose. Stocking. You prescribe some stocking. Stocking we prescribe only as a just prophylactic thing. It's not to be treated. When the patient already has recurrent thrombolism, then the answer treatment is inferior vena cava filter. One of the strongest indication of putting a filter. What they do? This is the heart. Okay, so this is the inferior heart, and this is the inferior vena cava. which come from the legs, and it is getting blood from this is inferior vena cava, right atrium. So now when the recurrent thromboembolic phenomena is there, then we put a filter here. Now filter will block, and now any clot which is coming will not be able to go to right atrium, and it will not be able to reach the lungs. So in such cases, indication is that in such cases, you always use filter. Okay. So let us learn what are the guidelines for the management of embolism, management of venous thromboembolism, VTE, as per 2020 guidelines of the NICE. They say use direct oral anticoagulant. This is always the first line treatment. Remember, in the previous discussion also, when we got a case, when we were investigating whether it was D-dimer or it was CTPA, what was the NICE guidelines? Start oral anticoagulant immediately. Don't wait for the investigation. Don't wait for the report. Start immediately. Okay, right. And one more thing. Second point. Initially they recommended low molecular weight heparin, but now straight away they say go for direct oral anticoagulant is the classical thing. The one major change which has occurred between the two. Okay. Well, anticoagulation therapy we talked about. Now, what about warfarin? Warfarin is now outdated drug. That's why especially showing you this. Warfarin is no more used drug. Okay, and always go for the oral anticoagulation. Now, one more question is there. For how long we have to give? Again, a very commonly asked question. For how long I have to give the treatment? Length of anticoagulation. So if I have to tell you the summary, oral anticoagulant, no role of warfarin, no role of low molecular weight heparin, go for oral anticoagulation. We put filter if the recurrent embolism is there. Now for how long? At least 3 months. Is it enough? Not at all. Well, now little bit more advanced. He says, in the meantime, you have to assess whether this thrombosis is provoked or unprovoked. Note down these two words. Whether it is provoked or unprovoked. Now you are definitely going to ask me, what do you mean by provoked? Provoked means there is definitely a precipitating factor is there. Definite. Patient had his surgery and he was bedridden for 3 months or long time. The patient had a delivery, she was on the bed for a long time. So we really have a definite predisposing factor. Then we call it to be provoked. And in unprovoked, there is no reason. Suddenly the patient developed anticoagulation, suddenly patient developed pulmonary embolism. There is no predisposing. This we call as unprovoked. Got it? So now the NICE guidelines say, in provoked, give for 3 months. Give for 3 months. But the patient has cancer, then you can go for 3 to 6 months. But if the patient is unprovoked, give for 6 months. So friends, if I have to give you summary of so far, the treatment of pulmonary embolism, oral, that is direct oral anticoagulant, directly acting oral anticoagulant like apixaban. Recurrent, go for filter. For how long? 3 to 6 months. 3 months is provoked and unprovoked is 6 months. This is summary. This is only summary, lovely summary in just 2 lines. 3 months and 6 months. 3 months is provoked. This is unprovoked. Unprovoked. Now, when to use thrombolysis? If there is hypotension is there, also called hemodynamic instability, that means hypotension is there. Hypotension, go for thrombolysis. Very simple. Okay, otherwise it is usually not done. So friends, golden line to remember: patient with recurrent venous thrombosis, you should consider for inferior vena cava filter. Golden line to remember. 52-year-old woman, breast cancer, acute dyspnea, respiratory rate is 42, saturation is low, pulmonary embolism is suspected. You treat with oxygen and an enoxaparin. Strongest indication for thrombolysis is hypotension. Extensive deep vein thrombosis is not an indication of thrombolysis. Patient choice, no way. Patient has no authority to choose the type of treatment. Type of treatment is to decide by the doctor. Then once he decide, then only he take the consent. Hypoxemia despite high way oxygen, no. EC showing lysis, no. So friends, this is the golden line to remember. Massive pulmonary embolism with hypotension, then you do the thrombolysis. Golden line to remember. A 45-year-old female, pleuritic pain chest, CTPA confirmed embolism. Okay, she had a hysterectomy 10 days ago. For how long? 3 months. Why? It's a type of provoked pulmonary embolism. We have a reason. Hysterectomy done, patient was on the bed, so we definitely have a reason. It's a type of provoked. You have to give for 6 months. Suppose there was no history of any surgery, etc., then the answer would have been 6 months, unprovoked. Provoked, you have to give for 3 months. Golden line to remember in provoked pulmonary embolism. Note down all these golden lines. These are the answer to your questions in the exam. They are going to ask you this question only. So provoked pulmonary embolism are typically treated for 3 months and unprovoked for 6 months. Normal, a middle-aged lady, pleuritic pain chest, 10 days having a hysterectomy and suspicion of pulmonary embolism. Most common chest X-ray finding is normal. You remember in the very beginning I told you chest X-ray is usually normal. Okay, otherwise there can be little bit of pleural effusion. There can be dilatation, right heart enlargement may be there. All other findings can be there, but majority of time chest X-ray is normal. So go for this answer. So the golden line to remember. The golden line to remember is in a case of pulmonary embolism, chest X-rays are usually normal. 65-year-old lady, COPD patient, sudden worsening of her dyspnea with hemoptysis. What is the best initial to exclude pulmonary embolism? Now the answer is CTPA. He has COPD and now you want to rule out pulmonary embolism, go for CTPA. And in one of the previous questions, we learned that patient had the renal problem. Then VQ scan was the answer. So I hope that your doubts are very clear now. Crystal clear concepts are there that in case of renal failure, go for VQ scan, otherwise go for CTPA. Okay. Now, one more golden line. CTPA is the first line investigation. But again, NICE guideline does accept, it's still common in UK hospital to do VQ scan. Point to be noted, NICE guideline itself say that although CTPA is the first investigation, but NICE guideline also says despite our guideline, practically, look, NICE has to give guidelines, but practically the treating physician has to say they still go for VQ scan. This point should be noted. Question 8, shortness of breath, pulse 114, BP 106, respiratory 30, and arterial and pH 7.41, PCO2, PO2 7.2. Following the initiation of oxygen therapy, next step in the management is, so now things are clear to you. He is suspecting the patient to be having shortness of breath, tachycardia, BP is low, respiratory rate is high, and you are suspecting a case to be off, or even a PaO2 is also less, hypoxia is there, then what the first line treatment is oral rivaroxaban is the first line treatment for a case of pulmonary embolism. I don't think I need to discuss. This we use in asthma. This again we use in asthma. IV fluid has no role and cotrimoxazole has no role. If you go by rule out technique also, none other drug is used in a case of pulmonary embolism. So in a suspected pulmonary embolism, the first line treatment is always direct oral anticoagulation. Question 9, 74-year gentleman, shortness of breath, dry cough, no sputum, okay, and he take ramipril and temlucin, smoke 10 cigarettes per day for 20 years. The consumption pain, chest is clear, rate is 24, saturation is 91%, heart rate 105, BP, chest is normal, and blood result is as follows. Okay. CRP 29 is there, neutrophils, and WBC count is fairly normal. So what you are getting a picture which just suggests that we are dealing with a case of pulmonary embolism. Point in favor are shortness of breath, dry cough, and saturation is low, respiratory rate is, tachycardia is there, chest X-ray normal, blood EC shows sinus tachycardia. So there are many features which indicate that he has got unprovoked pulmonary embolism. And in this case, CT angiography is the next best investigation. Okay. Blood culture will be useful only in case of pneumonias. D-dimer we will use only when we are suspecting the well score is less than 4. Pulmonary function test has no special role to play in pulmonary and arterial blood gas. It's just a suggestive, not a diagnostic of pulmonary embolism. This is going to give you a diagnosis whether patient has pulmonary embolism or not. Okay. Question 10. We are getting a 57-year lady, shortness of breath, and she has been diagnosed with pulmonary embolism, and we started with apixaban. For how long you have to give? No past history of medical illness. So now is a case of what? It's a case of unprovoked pulmonary embolism. What treatment? For how long? 6 months. So in the previous, one of the previous question, we got a patient with a hysterectomy, we gave for 3 months. That was provoked. This is unprovoked. We give for 6 months. So friends, golden line to remember. Unprovoked should be given for 6 months, and in provoked it should be given for 3 months. Thank you very much. God bless all of you.